Good day. I'm Dr. Benjamin Van Raalte, and I'm a board-certified plastic surgeon, and today we're going to talk about breast augmentation, period. I'm going to go through the steps I normally do with a consultation. Of course, we can't do an examination today that we would normally do, but we will go through everything that we talk about. What we normally start with in our consultation is we do have an educational video from the American Society of Plastic Surgeons that gives background information, and we show our before and after pictures, some of which are available on our website today. But what I will do is go over what I tell patients about the procedure and their options. What we usually start with is finding out a little bit about the patient. I ask them, have they had children? Have they had any breast surgery? Any large weight gain or loss? Those things might determine how much the skin is stretched out, or whether there's need for additional procedures, such as correcting droop or need for a lift. We'll ask what their desires are. Of course, we can't make any guarantees. We can't make guarantees about cup size for many reasons. First of all, many women are in the wrong bra size. Second of all, most manufacturers cut their bra sizes differently. And lastly, for example, if let's say you're a 36B, it's actually the same volume as a 34C. So whether you buy the 36B or the 34C, and how you like to fit it depends on what cup size you'll actually be. Nonetheless, we take what the patient's asking to determine what they're thinking in terms of size of the implant. Now that'll determine the projection of the implant. The second thing that'll determine the size is the width of the patient's chest. Contrary to what a lot of people believe, the same size implant isn't going to look the same on different people. A larger person with a wider chest, one implant may actually look small. And in a smaller person with a narrower chest, that same implant may look very large. So the width of the chest from here to here determines one factor of the implant size, and then the skin envelope, or what the patient wants or what can fit, is the projection, and that determines our implant size. Then what we talk about is the types of implants, and I have all three here. What we had for many years alone is the saline implant. Saline implants were all we had from about 1992 to the mid-2000s. Their advantage are they are the least expensive. They do deflate, or at about a rate of 1% per year, and then the implant will go totally flat and need to be replaced. They also, as you can see, tend to have more wrinkling or rippling, especially in thinner patients. The gel implants we had, again, starting in the mid-2000s. We had them previously prior to the early 90s. The gel implants have a much more natural feel. They have less rippling and wrinkling than the saline. They are a little more costly, and people do like the feel of these implants. The rupture rate for these implants is about 1% per year. Then about 2 years ago, or in about, we had the addition of the cohesive gel implants, or known as the gummy bear. They were widely available in Europe and in Brazil for about 10 years now. So the data that we have is very good. They are a little firmer than the regular gel implants. The advantages are they hold the shape and can have a very natural look. They also seem to hold the shape of the breast over time with less bottoming out or stretching or falling off to the sides. They do take a larger incision because you can't fold them up and fill them like the saline ones do. For the cohesive gel, the data is showing a rupture rate of about 0.5% per year. They're also reported to have a 1% chance of turning, although in patients placed for the first time due to them adhering to the tissue, this may be lower. These are the most expensive just because they're the newest and most costly. I tend to find a lot of advantages for the cohesive gel or gummy bear implants. All three seem to look good at first, and all three in many patients will turn out well. I do think, though, over time, the cohesive gel or gummy bear need less reoperations, and for some patients seem to hold the shape of the chest better. Patients that we put a saline in and sometimes the regular gel will tend to stretch out over time and fall off to the side, and what looked good initially 5 years later doesn't look as good. And for that reason, whenever possible, I recommend the cohesive gel or gummy bear implants. The next thing I'm going to talk about is placement of the implants. You can put the implants above the muscle or below the muscle. For many years, we put the overwhelming majority of the implants below the muscle. It tends to give a little bit more natural look. It has the muscle then cover the implant, at least the upper pole, so there's less visibility. It was felt for many years to have less capsules, which is a scar tissue that forms around the implant and makes it feel hard. So that's been the overwhelming majority. Our friends that in overseas that have been using the cohesive gel implants, though, have been putting them what's subfascial. That means it's below the fascial layer but above the muscle. The advantages of that are it is less painful. It does correct droop better because then the implant can fill in some of the droopy breast. Not for a lot of droop, but for a little bit of droop. And for some patients who may be competitive bodybuilders, they don't get the flexing of the muscle over the implant. There probably still is some higher rates of capsular contracture. There probably still is some increased rippling or visibility of the implants, but our friends overseas say the rate of that is fairly low, so that subfascial in selected patients may be a good option. Then we have the choice of what incision to place the implants. You can put it through an armpit incision, you can put it through the incision underneath the breast, or an incision through the nipple. I don't recommend through the nipple for several reasons. The Raalte, you're cutting through breast ducts, so I do feel there's higher rates of capsular contracture and infection, as well as increased numbness. My two favorite incisions are either the axillary or armpit incision or underneath the breast. The axillary works really well when we're using a round or a saline implant, or not too large an implant. The incision underneath the breast works better when we're trying to correct some droop, or using a larger implant, or the cohesive gel or gummy bear implants. And we go over that with each patient and individualize them as well. So that's the placement of the implants above or below the muscle and the different incision types. Well, now we're going to discuss the risks of the procedure. It may seem like this is something that we shouldn't go over, as it may be a little bothersome or even scary to some patients, but these risks do occur. In fact, one thing I was told in training is any surgeon who tells you that there's no risks or he doesn't have risks, you should probably run from, because all good surgeons doing enough procedures will have complications. I'm going to go over the national averages that are quoted for these procedures. Mine, for many of these, are much lower, but I want to go over what has been published. The risks fall into two groups: those due to the implants themselves, and then those due to the surgery. Okay. There have been multiple studies on the implants and safety of the implants over the years. What we do know is women getting implants are not a random group. Nobody's done a study saying this many women have to get implants and these women don't. So by and large, thinner women with less breast tissue tend to get more of the implants. For that reason, thinner women with less breast tissue may be more prone to something. In fact, epidemiologists have been surprised there haven't been higher rates of certain things just because it's a non-random group. There have been several studies showing women with implants actually have lower rates of breast cancer. Doesn't mean the implants protect them, but it probably tells us that the women who get breast implants are less prone to breast cancer. What we do know is there's things related to the implants. We put scar tissue around any foreign object in our body, whether we get a pacemaker, whether we get a hip replacement, whether we get a breast implant. The scar tissue around the breast implant can feel too hard in a few people, and it's called a capsule. The rate of overly hard capsules around implants is reported at about 1% a year. And in some cases, they may have another procedure to reoperate on that capsule. The implants might interfere in some cases with mammograms, and certainly most women with implants will need to get an extra view to visualize the breast tissue. The implants may show signs of rippling or wrinkling, especially in people with thin tissue over them. As I mentioned, the cohesive gel implants seem to have the lowest rate of that. The only thing that I have heard reported is out of the 10 million women with implants, there's been 80 cases of a rare cancer abbreviated as ALCL. Those have been treated by removal of the implants and the scar tissue. They think there may be a foreign body effect, and there is research being done to see if it's a particular type of implant that may be more prone to that. At this time, we do not have that information. The risks due to the style of implant. We do know that the cohesive gel take a larger incision. I already mentioned that they do have a slight risk of turning. So that's the only difference due to that implant. The gel implants, this cohesive gel, rupture at about 0.5% per year. The regular gel at about 1% a year. And the salines deflate at about 1% a year. I do not know of any health problems reported with a ruptured implant to date. So that's our risks due to the implants themselves. There may be more. This is not meant to be a comprehensive list of all of them, but those are the more common ones that I know of and discuss. Next, I'm going to talk about surgical risks, and some of these risks are common to any surgery that you would have. For example, we have to make an incision and there will be a scar. And we know some people in the population tend to form thicker or redder scars. In breast surgery, the rate of an excessively thick scar is less than 1%, but that can occur. Anytime we do a procedure, there's a risk of bleeding or hematoma. The rate of that is reported at about 1%, and the treatment for that is we have to reopen it up, rinse it out, and replace the implant at that time. You can limit that risk by avoiding things that cause bleeding. We tell our patients no aspirin, Motrin, Nuprin, Aleve for 2 weeks before the procedure. Those all increase your risk of bleeding. Tylenol is the only safe one. There is a 1% chance of permanent nipple numbness. Not so much from cutting the nerve, but just from stretching underneath. The other two risks are a little bit more bothersome. Our patients are covered in bacteria, and although we give antibiotics and although we scrub them prior to surgery, we don't eliminate all the bacteria. Therefore, there is a 1% chance of infection despite being careful. And with a breast implant, an infection, and despite using the antibiotics, it may result in loss of the implant. In other words, we have to take the implant out to resolve the infection. We then have to wait 3 months and replace the implant. The other risk that could result in another surgery is asymmetry. What I like to point out to patients is, contrary to how they perceive it, we're not snapping new breasts on the outside. They're not buying breasts and putting them on. We're putting an implant inside their skin envelope, which is different in most people. Most women, their left chest is wider. One breast may be saggier or shaped different. The skin may be either looser on one side or tighter, and all those factors will affect how it shapes then on that side. In extreme cases, the tighter skin could push the implant higher, like a rubber band. Many of our patients we have wear an elastic strap after the surgery to help the implant not get pushed up and to stretch out the lower skin while it's healing. But about 1% of the patients, it doesn't stretch out as well, or that skin is tighter, and then that one implant ends up higher or lower on the one side. Occasionally both sides can be malpositioned. So about 1% of the patients will need another procedure to reposition the implant because their tissue is either different or looser or tighter that affects how it heals. We are not snapping the new breast on the outside, and we're relying on that skin envelope that way. Some patients are disappointed by the surgery. That goes back to what I've just mentioned. We're not attaching a new breast on the outside. You're not picking your new breasts out of a catalog. And patients who feel that they're going to pick out a certain breast and that's what they're going to get may be disappointed in that regard. Some cases are harder than others. Some patients have tight skin or what's called a tubular breast that may need additional considerations. Droop always has its own consideration to correct. It may mean a larger implant. It may mean subfascial placement of the implant. It may mean discussion of a lift for the saggy tissue. And of course, a lift and an implant are really two opposing operations, the lift being a tightening operation and the implant being a stretching operation. So there's lots of factors that affect the final outcome. That's when we do our examination, we try to point out factors from asymmetry to the shape of the breast that may affect what to anticipate or what we end up needing to do. What I do encourage you to do is to make sure you're going to a board-certified plastic surgeon. That's someone who's been trained in a residency in plastic surgery, not someone who just says, I want to do this. Those people are reputable and should tell you all the risks, do a good assessment, and do a good procedure for you. Thank you.